Assalamu alaikum. Welcome everybody from the platform of BYOS Academia, the scientific platform where we can share the knowledge for the young generation, especially young ophthalmologists. This is from Dr. Masudul Hasan. I would like to present the topic about evaluation and management of fungal corneal ulcer. Actually, the main objective of fungal corneal ulcer management to identify the fungal pathogens, epidemiology, pathogenesis, diagnostic methods, therapeutic intervention, prevention and management. Fungal corneal ulcer, potentially sight-threatening ocular condition and leading causes of monocular blindness in the developing countries. This particular form of keratitis is often difficult to diagnose and manage. So, it is very important for early recognition and proper management is of utmost importance. What is corneal ulcer? Actually, there is loss in the continuity of the corneal epithelium associated with tissue infiltration and necrosis. And the main pathogenesis is a defect in the epithelium. Fungi enter into the corneal stroma and then multiply and proliferate. Severe tissue necrosis and inflammation occurs and often decimates membrane penetration to the anterior chamber and hypopyon is formation. The main stages are stage of infiltration, stage of progression, stage of regression and stage of cicatrization. Main predisposing factors, especially in fungus, trauma. Very oftenly, the main cause of fungal keratitis is agricultural trauma, oftenly domestic trauma, dust injury, sometimes ocular disease, and sometimes non-specific causes and often systemic immunocompromised patient leading to cause fungal keratitis. And the responsible fungus which leading to fungal keratitis most commonly the filamentous fungi, especially non-pigmented Aspergillus and Fusarium, and sometimes pigment producing fungus also leading to fungal keratitis. Yeast, the Candida albicans, another fungus, and sometimes dimorphic fungus also causes keratitis. The demography shows especially the day labor and farmer the most victim of the fungal keratitis, sometimes service holder, businessmen, unemployed. And demographic data, we see the male are more affected than female, as because the male are more doing the outdoor activities in our country. So finally, the management options, very important issues, careful history taking. It is very much important to proper history from the patients to find out the underlying causes of the ulcer. It will give us an idea of the origin and type of microorganism which is involved in keratitis. It also helps us to counsel the patient according to avoid the similar situation and prevent it from the happening again. The most common causes of fungal keratitis is Aspergillus and Fusarium, and the main sign is keratitis is feathery margin, sometimes the satellite lesion, and hypopyon, which is thick in nature, and sometimes double layered hypopyon. And sometimes we clinically also found the pigment producing fungus and brown pigmented into the corneal epithelium and stroma, which is the clinically confirmed that is fungal keratitis. And color and sometimes grayish infiltrate, creamy exudate, and irregular feathery margin. That is very much characteristic features of fungal keratitis. And sometimes the infiltrate is a collar button configuration. That is also a significant changes of cornea that lead to fungal keratitis. So main things for management is documentation, find out the specific pathogens and treatment. For documentation, anterior segment photography and color coded corneal diagram, and for find out the specific pathogens we should perform the corneal scraping for KOH, gram staining, and culture and sensitivity test. For fungus, the Seborrheic agar is the most common, and blood agar and sometimes brain heat infusion agar is also used. And for confirmation, we should perform the confocal microscopy and PCR. That leads to very specific organism to find out. And others coexisting test is sac patency test and blood sugar status of the patient, especially HbA1c, who are suffering from diabetes mellitus. Color coding, especially we should document it clinically, that is very important, that is epithelium defect, the size of the epithelium defect, corneal infiltration, corneal edema, vascularization, and especially hypopyon. For regular follow-up, the measurements of the hypopyon is very important. And specific guidelines for the corneal scraping, when corneal infiltrate is central, larger, and associated with significant stromal involvement or stromal melting, the infection is chronic on or unresponsive to broad spectrum antibiotic therapy, and sometimes it involves the limbus and one-eyed patient, then it should be carefully the corneal smear is collected and find out the specific organism. For the management purpose, we should choose the pharmacological agent, especially topical, systemic, and sometimes intervention is needed. For topical, especially natamycin, the particular recommended for the filamentous fungus, especially Fusarium, and topical amphotericin B, highly effective in cases of yeast keratitis, Sassos candida. And amphotericin B is also recommended for the filamentous keratitis, especially Aspergillus group. And systemic antifungal, ketoconazole, fluconazole, itraconazole, and sometimes we also use the oral voriconazole. And duration should be 6 to 8 weeks, and periodic systemic evaluation, especially complete blood count, liver function test, and chest X-ray for the systemic evaluation, the patient who getting the systemic antifungal drugs. And sometimes the pharmacological target drug delivery system, especially we use the intracameral antifungal drug, and sometimes we also inject the intralesional, intrastromal target drug delivery system. That is very important, especially two drugs we use, voriconazole and amphotericin B. So these two method of drug delivery is very much important in non-responsive to topical antifungal drugs. And good activities, especially natamycin, which are very important for Fusarium aspergillus but less effective against the Candida, and we can use it intracameral, but it is not available in our country. And natamycin is the first antifungal FDA approved drug, and it is used as monotherapy for the superficial infections, especially fungal, and combined with azole antifungal oral treatment for severe infection. And especially amphotericin B, which is first line therapy for Candida, and we can use it topical, intracameral and intrastromal. It is used mainly for the management of superficial fungal keratitis. Its effectiveness depends on the severity of the disease. And voriconazole, it is good activity against the Candida and aspergillus, good for moderate activity against the Fusarium species. And we can use it topical, oral, intrastromal and intracameral. It is very good drug for Candida and aspergillus, especially in intracameral. The result is very good. And sometimes we needed the surgical intervention, especially epithelium debridement, and it should be periodic, especially in pigment producing fungus. And sometimes we have to make a conjunctival flap, sometimes amniotic membrane transplant, sometimes corneal tectonic patch graft, and finally therapeutic lamellar keratoplasty or therapeutic penetrating keratoplasty. Dear viewers, I would like to inform you that is the tips and tricks for therapeutic penetrating keratoplasty, my next episodes. So, what are the main indication for surgical, especially therapeutic penetrating keratoplasty? The patient with progressive disease despite the maximum topical and oral antifungal therapy, and the main aims of the intervention to prevent the scleral or intraocular extension of the fungus. However, the prognosis is for surviving of the eye, and we should be careful in epithelium debridement, especially the deep-seated infiltration and when the decimetocele and impending to perforation. So it is very careful, that is the cornea may leads to thinning and perforation may occur iatrogenic during the epithelium debridement or corneal scraping. And it should be take care, especially conjunctival flap or amniotic membrane. It is not too early. It should be at least long standing keratitis, especially non-responsive to topical and oral medication, at least non-healing stage, at least we clinically used to practice 3 months, 2 to 3 months non-responsive to oral or topical medication, then the conjunctival flap or amniotic membrane transplant can be performed. So, must remember for the management of the corneal ulcer, first the diagnosis of the disease, proper history taking, specification of the pathogens, especially the culture and sensitivity test, and planning for topical, oral, target base or surgical intervention. It should be planned for proper management of the fungus. And finally, before thanks, we should remember that prevention is more scientific than cure. So, the main leading cause of fungal keratitis is agricultural trauma. So, we should make a awareness, especially among the farmers during the cultivation season, that is prevention, take care of your eyes, and we can make a sense that is every farmer should use protective goggles during their agricultural activities. Thank you everybody for hearing me, and next time I will see again with another topic. Thanks BYOS Academia give me to the opportunity to share my knowledge. Thank you.